I'm about to reveal the biggest lie your doctor tells you about lowering blood pressure. And then I'm going to give you 12 strategies that actually work. Not one strategy, 12. Because there is no single best way to lower blood pressure. Your body is not that simple. Hypertension has 6 different mechanisms, 6 different pathways that raise your pressure. And if you only address one, you're leaving 5 untouched. Your pressure might drop 5 points, but it should drop 20. This is why patients come to me on 3 blood pressure medications, and their pressure is still 148/92. They're attacking one mechanism, maybe 2, but the other 4 are running wild, unchecked, raising their pressure, destroying their organs. I'm Dr. Claire Whitmore, cardiac surgeon for 20 years, and I've spent 2 decades repairing the damage caused by uncontrolled hypertension. I've seen the strokes, the hemorrhages, the brain tissue that's dead because blood pressure spiked to 200 and a vessel ruptured. I've seen the hearts, stiff, scarred, unable to relax because years of elevated pressure caused the muscle to hypertrophy and fibrose. I've seen the kidneys, shriveled, failing, covered in scar tissue because elevated pressure destroyed the glomeruli one by one until there weren't enough left to filter blood. And every time, when I ask the patient what they did to lower their blood pressure, they say the same thing. I cut out salt, or I started walking, or I tried the DASH diet for a few weeks. One strategy, maybe 2, never comprehensive, never sustained, and their pressure never normalized. It dropped from 160 to 145, still elevated, still destroying organs, still progressing toward the complications that landed them in my operating room. So today, I'm giving you everything. Every strategy that's been proven in randomized controlled trials to lower blood pressure. Not theory, not wishful thinking. Studies with hundreds or thousands of participants showing measurable, sustained blood pressure reduction. And I'm going to tell you exactly how much each strategy lowers pressure, how long it takes, what the mechanism is, and how to combine them for maximum effect. Because when you combine these strategies, when you attack all 6 mechanisms of hypertension simultaneously, you can drop your blood pressure 20 to 30 millimeters of mercury. That's the difference between stage 2 hypertension and normal. That's the difference between 3 medications and 0 medications. That's the difference between a stroke and a healthy brain. Stay with me, because by the end of this video, you'll understand why your current approach isn't working. Why cutting salt alone dropped your pressure 5 points but left you at 140. Why walking 30 minutes a day helped but didn't normalize your numbers. And you'll have a complete protocol. Multiple strategies, each targeting a different mechanism, each proven to work, combined into one comprehensive approach that actually normalizes blood pressure. But first, you need to understand what blood pressure actually is, and why it's so hard to control with a single intervention. Your blood pressure is determined by 2 things: cardiac output and peripheral resistance. Cardiac output is how much blood your heart pumps per minute. Peripheral resistance is how hard it is for that blood to flow through your arteries. Blood pressure equals cardiac output times peripheral resistance. If either one goes up, pressure goes up. If both go up, pressure skyrockets. Now, cardiac output is determined by heart rate and stroke volume, how fast your heart beats and how much blood it ejects with each beat. If you're stressed, your sympathetic nervous system activates. Heart rate increases, stroke volume increases, cardiac output goes up, pressure rises. If you're overweight, you have more tissue to perfuse, more blood volume. Your heart has to pump harder. Cardiac output increases, pressure rises. Peripheral resistance is determined by how constricted your arteries are. If your sympathetic nervous system is overactive, your arteries constrict. Resistance increases. Pressure rises. If your endothelium is dysfunctional, if it's not producing nitric oxide, your arteries can't dilate properly. They stay constricted. Resistance stays high. Pressure stays elevated. If your arteries are stiff, if they've lost elasticity due to aging or atherosclerosis, they can't expand to absorb the pressure wave from each heartbeat. Resistance is high. Pressure is high. If you're retaining sodium, your blood volume increases. More volume in the same space means higher pressure. If your renin-angiotensin-aldosterone system is activated, Your kidneys hold on to sodium and water. Blood volume expands, pressure rises, and your vessels constrict. Resistance increases, pressure rises further. These are 6 different mechanisms: sympathetic overactivity, excess blood volume, sodium retention, endothelial dysfunction, arterial stiffness, RAAS activation. And in most hypertensive patients, multiple mechanisms are operating simultaneously. This is why a single intervention doesn't work. If you cut sodium but your sympathetic nervous system is overactive, your pressure drops 5 points but stays elevated. If you lose weight but your endothelium is dysfunctional and your arteries can't produce nitric oxide, your pressure improves but doesn't normalize. You need to attack all 6 mechanisms. And that's what these 12 strategies do. Each one targets one or more mechanisms, and when you combine them, you create a synergistic effect that's more powerful than the sum of the parts. Let me show you. The first strategy is the DASH diet. Dietary approaches to stop hypertension. This is the most studied dietary intervention for blood pressure in the history of medicine. The original DASH trial, published in 1997, randomized 459 participants to 3 diets: a control diet, typical American eating; a fruits and vegetables diet, which increased fruits and vegetables but kept everything else the same; and the DASH diet, which was rich in fruits, vegetables, low-fat dairy, and reduced saturated fat. They followed them for 8 weeks. At the end, they measured blood pressure. The DASH diet reduced blood pressure by 5.5 over 3.0 millimeters of mercury more than the control diet. Statistically significant. But here's what's remarkable. When they looked at just the hypertensive participants, 133 people with baseline blood pressure above 140 over 90, the reduction was 11.4 over 5.5 millimeters of mercury. 11 points systolic, 5 points diastolic, in 8 weeks. From diet alone. That's the equivalent of 1 blood pressure medication. And this wasn't a starvation diet. This wasn't juice fasting. This was real food: fruits, vegetables, whole grains, lean protein, low-fat dairy. But the DASH diet alone isn't enough for most people, because it doesn't address sodium. So they did another study, the DASH sodium trial. They combined the DASH diet with 3 levels of sodium intake: high, 3,300 milligrams per day, which is typical American intake; intermediate, 2,300 milligrams; and low, 1,500 milligrams. They randomized participants to DASH diet or control diet, and within each group to one of the 3 sodium levels. The results were stunning. DASH diet with low sodium produced a blood pressure reduction of 7.1 millimeters of mercury in people without hypertension, and 11.5 millimeters of mercury in people with hypertension. This is comparable to a single blood pressure medication, but without side effects, without cost, without the need to take a pill every day for the rest of your life. Now let me show you what the DASH diet actually is, because most people have heard of it but don't know what it means. DASH diet daily servings: 4 to 5 servings of fruits, 4 to 5 servings of vegetables, 6 to 8 servings of whole grains, 2 to 3 servings of low-fat dairy, 6 ounces or less of lean meat, poultry, or fish, 4 to 5 servings per week of nuts, seeds, or legumes, 2 to 3 servings of healthy fats and oils, 5 or fewer servings per week of sweets, and critically, sodium intake below 2,300 milligrams per day, ideally below 1,500. A serving of fruit is 1 medium apple, banana, orange, or half a cup of berries. A serving of vegetables is 1 cup raw leafy greens or half a cup cooked vegetables. A serving of whole grains is 1 slice of whole wheat bread or half a cup of cooked brown rice, quinoa, oatmeal. A serving of low-fat dairy is 1 cup of milk or yogurt. Lean protein is measured in ounces, 6 ounces total per day. That's 2 3-ounce servings, the size of a deck of cards each. Nuts and seeds are measured by the handful, about 1 ounce. 4 to 5 times per week, not daily because they're calorie-dense. Healthy fats are olive oil, avocado, 2 to 3 servings per day. 1 serving is 1 tablespoon of oil or a quarter of an avocado. This is not restrictive. This is not deprivation. This is normal eating with an emphasis on whole foods and a de-emphasis on processed garbage. And it works. A meta-analysis of 30 randomized controlled trials, 5,545 participants total, confirmed the effect. Average reduction, 6.74 millimeters of mercury systolic, 3.54 diastolic. Greater effect in people who were hypertensive at baseline. Greater effect when combined with calorie restriction for weight loss. But here's the timeline. You don't have to wait months to see results. Week 1 to 2, initial blood pressure reductions begin. Week 4, significant measurable changes. Week 8, full effect achieved. And long-term, the effect is sustained as long as you maintain adherence. Now let me tell you about Margaret. She was 68 years old when she came to me. Blood pressure, 152/94. She was on 2 medications, lisinopril and amlodipine. Her pressure was still elevated. Her nephrologist was concerned about her kidneys. Her GFR, glomerular filtration rate, was 62. Mild chronic kidney disease, caused by years of uncontrolled hypertension. I explained the DASH diet to her. She was skeptical. She said, "I've tried low-salt diets before. They don't work." I said, "This isn't just low salt. This is a complete dietary pattern that addresses multiple mechanisms. Potassium from fruits and vegetables, calcium and magnesium from dairy, fiber from whole grains, healthy fats. All of these work together." Margaret agreed to try. We gave her a meal plan, a shopping list, recipes. She followed it for 8 weeks. When she came back, her blood pressure was 136/84, down 16 points systolic, 10 points diastolic. Still elevated, but significantly better. We reduced one of her medications. She continued the diet. 12 weeks later, her pressure was 128/80. We reduced her second medication. 6 months later, she was off all blood pressure medication. Her pressure was 122/76, on diet alone. And her GFR had stabilized. It stopped declining. Her kidneys were protected because her blood pressure was finally controlled. This is the power of the DASH diet, but it requires adherence. Margaret didn't do it for 2 weeks and quit. She incorporated it into her life. It became her normal way of eating, and it saved her kidneys. Now the second strategy, potassium. This is the forgotten mineral. Everyone talks about sodium. Cut your salt, reduce sodium intake, but almost nobody talks about potassium. And potassium might be more important. A meta-analysis of 32 randomized controlled trials looked at potassium supplementation and blood pressure. They found a linear dose-response relationship. For every 0.6 grams of potassium increase per day, blood pressure dropped by 1.0 millimeter of mercury systolic and 0.52 millimeters diastolic. The optimal intake is 4.7 grams per day. That's 120 millimoles. At that level, average blood pressure reduction is 8.0/4.1 millimeters of mercury, 8 points systolic, 4 points diastolic, from a mineral. And here's what's critical. The effect is stronger when dietary sodium is high. Potassium protects against sodium. If you eat a high-salt meal, potassium causes your kidneys to excrete that sodium. It prevents the blood pressure spike. So even if you can't perfectly control your sodium intake, increasing potassium gives you protection. The mechanism is multiple pathways. First, natriuresis. Potassium causes sodium excretion through the kidneys. More potassium means more sodium in your urine, less sodium in your blood. Lower blood volume, lower pressure. Second, vasodilation. Potassium activates the sodium-potassium pump in vascular smooth muscle cells. It opens potassium channels. This causes the muscle to relax. Blood vessels dilate, resistance drops, pressure drops. Third, it inhibits the WNK pathway. This is a system that promotes sodium retention in the kidneys. High potassium deactivates it. Your kidneys stop holding on to sodium. They excrete it. Blood volume normalizes. Fourth, it modulates the baroreflex. That's your body's blood pressure control system. Receptors in your arteries sense pressure changes and adjust heart rate and vessel tone to keep pressure stable. Potassium improves baroreflex sensitivity. Your body gets better at regulating pressure automatically. Now here's the problem. Most Americans are potassium deficient. The average intake is 2,300 to 2,800 milligrams per day. The target is 4,700. We're getting half of what we need. And when potassium is low, blood pressure goes up. There was a study where researchers deliberately depleted potassium in normotensive subjects, people with normal blood pressure. They restricted dietary potassium for weeks. Mean arterial pressure increased from 90.9 to 95.0 millimeters of mercury, statistically significant. Then they gave these potassium-depleted subjects a high-sodium meal. Blood pressure spiked. But when they gave the same high-sodium meal to subjects with normal potassium levels, blood pressure didn't spike. Potassium protected them. This is why the sodium-potassium ratio matters more than sodium alone. The ratio of sodium to potassium in your diet and in your urine predicts blood pressure better than either mineral individually. The target ratio is less than 1. 1 milligram of sodium for every 1 milligram of potassium, or ideally, less sodium than potassium. But the typical Western diet has a ratio of 2 to 3, or higher. 2 to 3 times more sodium than potassium. This is backwards, and it's destroying blood pressure control. Now, where do you get potassium? Vegetables are the best source. Beet greens, 1,300 milligrams per cup cooked. Spinach, 840 milligrams per cup cooked. Swiss chard, 960 milligrams per cup cooked. Potatoes with skin, 900 milligrams per medium potato. Sweet potato, 700 milligrams. Fruits, banana, 420 milligrams per medium banana. Avocado, 690 milligrams per cup. Cantaloupe, 430 milligrams per cup. Legumes, white beans, 1,000 milligrams per cup. Lentils, 730 milligrams per cup. Other sources, salmon, 630 milligrams per 6-ounce serving. Yogurt, 570 milligrams per cup. To hit 4,700 milligrams per day, you need to eat multiple servings of these foods daily. This is why the DASH diet works. It's loaded with potassium-rich foods. Fruits, vegetables, legumes, dairy. Low-fat dairy specifically because full-fat dairy has the same potassium, but more saturated fat and calories. Now there's one critical caveat. People with kidney disease need to be careful with potassium. If your kidneys aren't functioning normally, they can't excrete excess potassium. It accumulates in your blood. Hyperkalemia. This is dangerous. It can cause cardiac arrhythmias. And people on certain medications, ACE inhibitors, ARBs, potassium-sparing diuretics, these drugs cause potassium retention. Adding more dietary potassium on top of these medications can cause hyperkalemia. So if you have kidney disease or you're on these medications, check with your doctor before increasing potassium. Get your potassium level tested. Make sure it's safe. But for most people with normal kidney function, increasing dietary potassium is one of the most effective interventions for blood pressure. 8 points systolic, 4 points diastolic. From eating more vegetables and fruits. The third strategy is resonance frequency breathing. This is the fastest intervention I'm going to describe. It works within minutes, but the effect is temporary. It lasts only while you're doing it, unless you train daily for weeks, in which case you get sustained benefits. Resonance frequency breathing is breathing at a rate that synchronizes your heart rate, breathing, and blood pressure oscillations. For most people, that rate is about 6 breaths per minute. Some people it's 5, some it's 7. You have to find your individual resonance frequency. When you breathe at this rate, you stimulate your baroreflex at maximum efficiency. The baroreflex is your body's blood pressure control system. Baroreceptors in your carotid arteries and aortic arch sense pressure changes. They send signals to your brainstem. Your brainstem adjusts heart rate and vessel tone to keep pressure stable. When you breathe at resonance frequency, you're training this system, making it more sensitive, more responsive. And acutely, while you're breathing, you're activating your parasympathetic nervous system, the rest and digest system. This counters sympathetic overactivity. Heart rate slows, vessels dilate, pressure drops. There was a study that tested this. They had participants do 15 minutes of resonance frequency breathing. Then they exposed them to a stress test, a difficult cognitive task designed to spike blood pressure. The group that did resonance frequency breathing had the lowest systolic blood pressure during the stress. the least blood pressure reactivity, and they reported higher positive mood. The breathing buffered them against stress. Another study looked at acute effects. 10 healthy men. They did 10 minutes of resonance frequency breathing. Researchers measured blood pressure and muscle sympathetic nerve activity. That's direct measurement of the sympathetic nervous system using a needle electrode in the nerve. Systolic blood pressure decreased by 4.6 millimeters of mercury during the breathing. Muscle sympathetic nerve activity decreased by 5.6 bursts per minute. The sympathetic nervous system was inhibited. The fight or flight response was turned down. This is sympathoinhibition, and it happened within 10 minutes. But the real power is long-term training. A 5-week study took pre-hypertensive participants and randomized them to resonance frequency training versus standard slow-paced breathing. The resonance frequency group had greater systolic blood pressure reductions, and the effect was sustained over weeks. Another 4-week study had young adults do 20 minutes of resonance breathing daily. After 4 weeks, their heart rate variability improved significantly. Heart rate variability is a marker of autonomic function. High variability means your autonomic nervous system is flexible, responsive, healthy. Low variability means it's rigid, dysfunctional, associated with cardiovascular disease. Resonance breathing improved it. Enhanced stress adaptation. Improved autonomic balance. Now, how do you find your resonance frequency? If you have a heart rate monitor, you can do this scientifically. Breathe at different rates. 4.5 breaths per minute. 5. 5.5. 6. 6.5. 7. Breathe at each rate for 2 minutes. Monitor your heart rate variability. The rate that produces the highest heart rate variability is your resonance frequency. If you don't have a heart rate monitor, approximate. For most adults, it's about 6 breaths per minute. That's 10-second cycles. Inhale for 4 to 5 seconds. Exhale for 5 to 6 seconds. The exhale should be slightly longer than the inhale. And critically, this must be diaphragmatic breathing, belly breathing, not chest breathing. When you inhale, your belly should expand. Your diaphragm descends. Your lungs fill from the bottom up. When you exhale, your belly contracts. Your diaphragm rises. Your lungs empty completely. Chest breathing, where your shoulders rise and your chest expands, is shallow. It doesn't activate the parasympathetic nervous system effectively. It can actually increase sympathetic tone. So breathe with your diaphragm. Slow, deep, smooth transitions, no breath holding, continuous flow. The timeline for resonance frequency breathing is unique. Within minutes, immediate blood pressure reduction during practice, but the effect wears off within hours of stopping. However, with daily practice, 15 to 20 minutes per day for weeks, you get sustained improvements in stress response. Your baroreflex becomes more sensitive. Your baseline sympathetic tone decreases. Your blood pressure stays lower even when you're not actively breathing. This is a tool. Use it when your pressure spikes. Use it when you're stressed. Use it before bed to calm your nervous system. And if you want long-term benefits, make it a daily practice. 15 to 20 minutes every morning or before bed. Sitting comfortably, back supported. Breathe at your resonance frequency. 6 breaths per minute for most people. This is one of the few interventions that works immediately, but it requires consistency for sustained effect. Before we continue with the remaining strategies, I need you to do something. Subscribe to this channel right now, because what I'm about to share in the next strategies could drop your blood pressure 10 to 15 points. And if you're not subscribed, YouTube's algorithm will bury this video. The next person whose doctor told them to just cut salt won't see it. They won't learn about potassium, about resonance breathing, about the other 9 strategies I'm about to explain. They'll do one thing. Their pressure will drop 5 points. They'll think that's as good as it gets. Subscribe so this reaches them. Hit that button and comment below. Tell me your current blood pressure. Tell me what you've tried. Because every comment signals to YouTube that this content is valuable, that it should be recommended to more people. Your comment could save someone from a stroke. Comment now. The 4th strategy is sodium reduction. This is the foundation. Everyone knows about it. But most people don't do it correctly. The average American consumes 3,400 milligrams of sodium per day. The recommendation is below 2,300. The optimal level for blood pressure is below 1,500. For every gram of sodium you reduce, blood pressure drops by 2 to 3 millimeters of mercury systolic in the general population, and 5 millimeters of mercury in hypertensive individuals. So if you're eating 3,400 milligrams and you drop to 1,500, that's a reduction of 1,900 milligrams, almost 2 grams. That's a 4 to 6 point drop in the general population, and an 8 to 10 point drop if you're hypertensive. The DASH sodium trial that I mentioned earlier showed exactly this. When they reduced sodium from 3,300 to 1,500 milligrams on top of the DASH diet, they got an additional 7 to 11 millimeter reduction beyond the DASH diet alone. But here's what most people don't understand. Salt sensitivity varies. Some people's blood pressure is extremely sensitive to sodium. They're called salt sensitive. If they eat a high salt meal, their pressure spikes 10 to 15 points. If they reduce salt, their pressure drops dramatically. Other people are salt resistant. They can eat high sodium diets and their pressure barely changes. Who's salt sensitive? Black individuals. More likely to be salt sensitive than white individuals. Genetic differences in sodium handling in the kidneys. Elderly people. As you age, your kidneys become less efficient at excreting sodium. You retain more. Pressure rises. People with hypertension. If you already have high blood pressure, you're more likely to be salt sensitive. People with diabetes. Insulin resistance affects kidney function. Sodium retention increases. People with chronic kidney disease. Impaired kidney function means impaired sodium excretion. Even small increases in sodium cause large pressure increases. If you're in one of these groups, sodium reduction is critical. It's one of your highest yield interventions. But even if you're not, reducing sodium helps. Because it's not just about the absolute amount of sodium, it's about the sodium-potassium ratio. A study in China, the Salt Substitute and Stroke Study, SSASS, gave people a potassium-enriched salt substitute, 75% sodium chloride, 25% potassium chloride. This reduced sodium intake and increased potassium intake simultaneously. The result was a 3.3 millimeter reduction in systolic blood pressure. But more importantly, it reduced stroke risk, reduced major cardiovascular events, and reduced total mortality. Not just blood pressure numbers, actual outcomes. Now, where does sodium come from? Most people think it's the salt shaker. It's not. 75% of dietary sodium comes from restaurant food and processed food. Only 10% comes from salt added at the table or during cooking. The top sources in the American diet are bread and rolls, 7% of total intake. Cold cuts and cured meats, 5%. Pizza, 5%. Processed poultry, 4%. Soup, 4%. Fast food sandwiches, 4%. Cheese, 4%. Pasta dishes, 3%. If you eat out frequently, if you eat processed food, you're getting massive amounts of sodium. A single restaurant meal can contain 3,000 to 5,000 milligrams. That's 2 to 3 days worth in one meal. So, sodium reduction isn't about throwing away your salt shaker. It's about cooking at home, eating whole foods, reading labels, avoiding processed garbage. The timeline for sodium reduction is fast. Within days, you lose water weight. Your blood volume decreases. Pressure drops. Within 1 to 2 weeks, your taste buds start adapting. Food that tasted bland at first starts tasting normal. You stop craving salt. By 4 weeks, you've achieved the full blood pressure effect. Your taste preferences have shifted. Low-sodium food tastes good. High-sodium food tastes too salty. And long-term, the effect is sustained as long as you maintain the new habits. Now the fifth strategy, weight loss. This is only relevant if you're overweight. If you're at a healthy weight, skip this. But if your BMI is above 25, if you're carrying excess weight, particularly around your abdomen, losing weight is one of the most powerful interventions for blood pressure. The data is clear. For every kilogram you lose, that's 2.2 pounds, blood pressure drops by approximately 1 millimeter of mercury, both systolic and diastolic. So if you lose 10 kilograms, that's 22 pounds, you drop your pressure by 10 points. The direct carotid study, which I mentioned in a previous video, showed that participants who lost more than 5.5 kilograms, 12 pounds, had the greatest plaque regression and the largest blood pressure reductions. The premier trial combined DASH diet with behavioral weight management. DASH alone produced an 11.2 millimeter systolic reduction. DASH plus weight management produced a 16.1 millimeter reduction, 5 points better. The control group, who didn't change diet or lose weight, had only a 3.4 millimeter reduction. Why does weight loss lower blood pressure? Multiple mechanisms. First, reduced cardiac output. When you're overweight, you have more tissue to perfuse. Your heart has to pump more blood. Higher cardiac output means higher pressure. When you lose weight, you have less tissue. Your heart doesn't have to work as hard. Cardiac output decreases. Pressure drops. Second, decreased sympathetic activity. Obesity is associated with increased sympathetic nervous system activation. Weight loss reduces that activation. Less adrenaline, less noradrenaline, lower heart rate, more vessel dilation, lower pressure. Third, improved insulin sensitivity. Obesity causes insulin resistance. Insulin resistance activates the renin-angiotensin-aldosterone system. This causes sodium retention and vasoconstriction. Weight loss improves insulin sensitivity. RAAS activation decreases. Pressure drops. Fourth, reduced inflammation. Obesity, particularly visceral obesity, fat around your organs, is a state of chronic inflammation. Fat cells produce inflammatory cytokines, IL-6, TNF-alpha. These cytokines impair endothelial function, reduce nitric oxide production, increase vascular tone. Weight loss reduces inflammation. Endothelial function improves. Vessels dilate. Pressure drops. Fifth, improved kidney function. Obesity impairs kidney function. It increases pressure on the kidneys. It activates the RAAS. It causes sodium retention. Weight loss improves kidney function. Sodium excretion normalizes. Blood volume decreases. Pressure drops. But not all fat is equal. Visceral fat, belly fat, matters most. A study comparing visceral fat reduction to subcutaneous fat reduction, fat under the skin, showed that visceral fat reduction had a much greater impact on blood pressure. Waist circumference is a better predictor of blood pressure than BMI alone. Target waist circumference. For men, below 40 inches, 102 centimeters. For women, below 35 inches, 88 centimeters. If you're above these numbers, you have excess visceral fat. Losing it will dramatically improve your blood pressure. The timeline for weight loss is gradual. Week 1 to 2, you lose water weight. Initial blood pressure improvement. This is encouraging, but it's not fat loss yet. Month 1 to 3, continued weight loss. Progressive blood pressure reduction. Each pound lost contributes. Month 6 and beyond, you reach a plateau weight. Your body adjusts. Blood pressure benefits are maintained at the new weight, but you need to sustain it. Regaining weight causes blood pressure to rise again. Robert was 58 years old, 5'10", 240 pounds, BMI 34, obese. Blood pressure 165/98, stage 2 hypertension. His doctor wanted to start him on 2 medications immediately. Robert asked for 3 months to try lifestyle changes. His doctor agreed, but was skeptical. Robert started the DASH diet. He cut sodium below 1,500 milligrams. He started walking 30 minutes every day. And he created a calorie deficit. He ate 500 calories less per day than he burned. Over 3 months, he lost 28 pounds, dropped to 212. Blood pressure came down to 142/86. Still elevated, but dramatically better. His doctor started him on 1 medication instead of 2, lisinopril 10 milligrams. Robert continued. 3 more months. Lost another 22 pounds, down to 190. Blood pressure 128/78. His doctor stopped the medication. Robert maintained his weight. 1 year later, still 190 pounds. Blood pressure 125/76. No medication. He reversed stage 2 hypertension with weight loss and diet. This is possible, but it requires commitment. You can't lose 10 pounds and quit. You have to get to a healthy weight and stay there. The 6th strategy is physical activity, both aerobic exercise and resistance training. The data on exercise and blood pressure is overwhelming. Meta-analyses of multiple randomized controlled trials show that aerobic exercise produces an average blood pressure reduction of 5 to 7 millimeters systolic and 3 to 5 millimeters diastolic. This is comparable to a first-line antihypertensive medication, and it's from exercise. No pills, no side effects, just movement. The optimal prescription, according to the American College of Sports Medicine, is 150 minutes per week of moderate-intensity aerobic exercise, or 75 minutes per week of vigorous intensity. Moderate intensity means you can talk but not sing. You're breathing harder than normal but not gasping. Brisk walking, cycling, swimming, elliptical. Vigorous intensity means you can only speak a few words before needing to catch your breath. Running, fast cycling, high-intensity intervals. 5 to 7 days per week, 30 to 60 minutes per session. If you do this consistently, your blood pressure will drop 5 to 7 points systolic. But resistance training also helps. 3 days per week, 8 to 10 exercises, 1 to 3 sets per exercise. The blood pressure reduction from resistance training is smaller, about 3 to 4 millimeters systolic, but it has other benefits: improved muscle mass, improved metabolism, improved bone density. Important: avoid the Valsalva maneuver during resistance training. That's holding your breath and straining during a heavy lift. This spikes blood pressure acutely, can cause dangerous elevations. Breathe continuously during lifts. Exhale during the exertion phase. Inhale during the relaxation phase. There's also a surprising finding about isometric exercise, exercises where you hold a static contraction without movement. Hand grip exercises are the most studied. You squeeze a hand grip device at 30 to 40% of your maximum grip strength. Hold for 2 minutes. Rest 1 minute. Repeat 4 times. 3 sessions per week. This produces about a 5 millimeter systolic reduction. Wall sits and planks have similar isometric benefits. The mechanisms of exercise are multiple. First, improved endothelial function. Exercise increases shear stress on vessel walls. This stimulates nitric oxide production. More nitric oxide means more vasodilation, lower pressure. Second, reduced arterial stiffness. Exercise improves arterial compliance. Vessels become more elastic. They can expand and contract more easily. This absorbs pressure waves from heartbeats, lowers systolic pressure. Third, enhanced autonomic balance. Exercise reduces sympathetic dominance, increases parasympathetic tone, lower resting heart rate, more vessel dilation, lower pressure. Fourth, weight loss. If you combine exercise with dietary changes, you lose weight. This contributes additional blood pressure reduction. Fifth, improved insulin sensitivity. Exercise makes your muscles more sensitive to insulin. Less insulin resistance means less RAAS activation, less sodium retention, lower blood volume, lower pressure. Now there are acute versus chronic effects. Acutely, immediately after exercise, blood pressure drops. This is called post-exercise hypotension. Blood pressure can drop 5 to 20 millimeters of mercury for 2 to 12 hours after a session. The drop is greatest in hypertensive individuals. This is why exercising in the evening can help control nighttime blood pressure. Chronically, with regular training over weeks, you get sustained reductions. It takes 4 to 12 weeks to see the full benefit. But the effect is powerful, and it's cumulative with other interventions. The timeline is immediate post-exercise, temporary blood pressure drop lasting hours. 4 to 6 weeks, consistent measurable reductions appearing. 12+ weeks, full chronic adaptations achieved. Sustained benefits as long as you continue training. The 7th strategy is limiting alcohol. The relationship between alcohol and blood pressure is J-shaped. Light drinking, 1 drink per day for women, 1 to 2 for men, is neutral or has a slight benefit. Moderate to heavy drinking, more than 2 drinks per day for men, more than 1 for women, causes dose-dependent blood pressure increases. 3+ drinks per day raises blood pressure by 5 to 10 millimeters systolic. 6+ drinks per day raises it by 10 to 20 millimeters. The mechanism is acute vasodilation, followed by sympathetic rebound. When you drink alcohol, your vessels dilate initially. Blood pressure drops. You feel relaxed. But several hours later, your sympathetic nervous system rebounds. Adrenaline surges. Vessels constrict. blood pressure spikes. This rebound can last 12 to 24 hours. Chronically, regular heavy drinking causes increased cortisol, impaired baroreceptor sensitivity, enhanced sympathetic activity, disrupted sleep, which raises blood pressure, and weight gain. Intervention studies show that reducing alcohol intake from 6 drinks per day to 2 drinks per day produces a 5.5 millimeter systolic reduction. Complete abstinence in heavy drinkers produces a 7.2 millimeter reduction. For blood pressure control, the recommendation is men, 2 drinks per day maximum, women, 1 drink per day maximum. Avoid binge drinking completely. Binge drinking raises blood pressure acutely and chronically. 1 drink equals 12 ounces of beer at 5% alcohol, 5 ounces of wine, or 1.5 ounces of spirits. The timeline is fast. Blood pressure drops within days of reducing alcohol intake. 1 to 2 weeks, significant reductions in heavy drinkers. 1 month, full effect achieved. The 8th strategy is sleep optimization. This is one of the most neglected factors in blood pressure control. But the data is clear. Sleeping less than 6 hours per night is associated with a 37% increased risk of hypertension. Poor sleep quality is an independent risk factor even if duration is adequate. The mechanisms are multiple. First, increased sympathetic activity. When you don't sleep enough, your fight-or-flight system stays activated, even during the day. Adrenaline stays elevated, heart rate stays high, vessels stay constricted, pressure stays elevated. Second, elevated cortisol. Cortisol, the stress hormone, is supposed to drop at night. When you sleep poorly, it doesn't. It stays high. High cortisol raises blood pressure through multiple pathways. Third, inflammation. Poor sleep increases inflammatory cytokines, IL-6, TNF-alpha, CRP. These impair endothelial function, reduce nitric oxide, increase vascular tone. Fourth, impaired glucose metabolism. Sleep deprivation causes insulin resistance. Insulin resistance activates RAAS, sodium retention, vasoconstriction, higher pressure. Fifth, disrupted circadian rhythm. Your blood pressure is supposed to dip 10 to 20% during sleep. This is called nocturnal dipping. It's normal and healthy. When you don't sleep well, you lose this dip. Your pressure stays elevated all night. Non-dippers have higher cardiovascular risk than dippers, even if daytime blood pressure is the same. But the biggest sleep-related cause of hypertension is obstructive sleep apnea. OSA is present in 30 to 50% of hypertensive patients, and 50 to 70% of OSA patients have hypertension. The blood pressure impact of untreated OSA is 10 to 15 millimeters systolic, plus loss of nocturnal dipping. Treatment with CPAP, continuous positive airway pressure, produces a 2 to 10 millimeter reduction. The effect varies based on severity and adherence, but it's greatest in patients with resistant hypertension. Patients on 3 medications whose pressure is still elevated. Often, the missing piece is undiagnosed sleep apnea. Treating it allows the medications to work. Pressure normalizes. The optimal sleep duration is 7 to 9 hours for adults. Intervention studies show that increasing sleep from 6 hours to 7 to 8 hours produces about a 5 millimeter systolic reduction in some studies. But sleep quality matters as much as duration. Things that improve sleep quality. Consistent schedule. Same bedtime and wake time every day, even weekends. This trains your circadian rhythm. Dark room. Darkness triggers melatonin production. Melatonin helps you fall asleep and stay asleep. Blackout curtains. No nightlights. Cool temperature. 60 to 67 degrees Fahrenheit. 15 to 19 degrees Celsius. Your body temperature needs to drop to initiate sleep. A cool room facilitates this. No screens 1 hour before bed. Blue light from phones, tablets, computers suppresses melatonin. It tricks your brain into thinking it's daytime. You can't fall asleep. No caffeine after 2 p.m. Caffeine has a half-life of 5 to 6 hours. If you drink coffee at 4 p.m., half of it is still in your system at 10 p.m. It impairs sleep quality. No alcohol close to bedtime. Alcohol makes you drowsy initially, but it disrupts REM sleep. You wake up frequently. Sleep quality is poor. The timeline for sleep optimization is days. Better sleep quality produces subtle improvements. Weeks, consistent 7 to 9 hours produces measurable blood pressure drop. Months, full circadian rhythm optimization achieved. The ninth strategy is stress management and meditation. Chronic stress is a major driver of hypertension. When you're stressed, your sympathetic nervous system is activated. Your HPA axis, hypothalamic pituitary adrenal axis, is activated. Adrenaline, noradrenaline, cortisol, all elevated. These hormones increase heart rate, increase cardiac output, constrict blood vessels, activate RAAS, cause sodium retention, impair endothelial function, reduce nitric oxide, and promote inflammation. All of these raise blood pressure. And chronic stress also affects behavior. You eat poorly, you exercise less, you drink more alcohol, you sleep worse. All of these worsen blood pressure. So stress management is critical. Transcendental meditation has been studied extensively. A meta-analysis of 107 studies, 960 participants, showed that transcendental meditation produced an average reduction of 4.7 millimeters systolic and 3.2 millimeters diastolic. This is similar to the effect size of weight loss or salt reduction. The mechanism is reduced sympathetic nervous system activity, decreased cortisol, improved endothelial function, and better parasympathetic tone. Mindfulness-based stress reduction, MBSR, is another approach. 8-week programs produce 5 millimeter systolic reductions commonly. Greater benefits in hypertensive versus normotensive individuals. MBSR includes body scan meditation, mindful movement like yoga, sitting meditation, and daily practice for 20 to 45 minutes. Yoga specifically has been studied. Meta-analyses show 5 to 10 millimeter reductions with regular practice, 3+ sessions per week. Yoga combines pranayama, breathing exercises similar to resonance breathing, asanas, physical poses that provide gentle aerobic activity, meditation for stress reduction, and relaxation for parasympathetic activation. Tai Chi has been studied in systematic reviews. 7 to 15 millimeter systolic reductions, 3 to 5 millimeters diastolic, particularly effective in elderly populations. Qigong, which combines breathing, movement, and meditation, shows 10 to 12 millimeter systolic reductions in some studies. Other techniques: progressive muscle relaxation, systematically tensing and releasing muscle groups, 3 to 5 millimeter reductions. Biofeedback, learning to control physiological responses like heart rate and blood pressure through real-time feedback, 5 to 7 millimeter reductions with training. The timeline for stress management is during practice, immediate blood pressure drop. Weeks, improved stress reactivity. Your blood pressure doesn't spike as high during stressful events. 2 to 3 months, sustained baseline reductions with daily practice. Your resting blood pressure is lower. Your body's stress response is less exaggerated. The 10th strategy is caffeine moderation. This is nuanced. Caffeine has a paradoxical relationship with blood pressure. Acutely, coffee or caffeine causes a 5 to 15 millimeter spike in blood pressure for 1 to 3 hours in non-habitual users. People who don't drink coffee regularly. But chronically, in regular consumers, tolerance develops. The blood pressure effect disappears. They can drink coffee daily and their blood pressure doesn't rise. However, if a non-consumer starts drinking coffee regularly, they may see sustained increases, at least initially. There's also individual variation. The CYP1A2 gene controls caffeine metabolism. Fast metabolizers break down caffeine quickly. They have minimal blood pressure impact. Slow metabolizers break down caffeine slowly. They may see chronic elevation. Caffeine sensitivity varies widely. 100 milligrams, 1 cup of coffee, affects some people significantly. Others can drink 400 milligrams with no effect. Current evidence suggests that moderate intake, 2 to 3 cups of coffee per day, 200 to 300 milligrams of caffeine, is generally safe for most people. It doesn't cause sustained blood pressure elevation in regular consumers. Heavy intake, more than 4 cups per day, more than 400 milligrams, may raise blood pressure in sensitive individuals. If you're hypertensive and you're caffeine sensitive, consider reducing or switching to decaf. Test it. Stop caffeine for 2 weeks. Measure your blood pressure daily. See if it drops. If it does, caffeine was contributing. If it doesn't, caffeine isn't your problem. Special consideration for energy drinks. They often contain 200 to 300 milligrams of caffeine per can, plus other stimulants, taurine, guarana. These are associated with higher acute blood pressure spikes than coffee. Avoid them if you're hypertensive. The timeline for caffeine is 30 to 60 minutes. Peak blood pressure increase after consumption. 3 to 4 hours, effect wears off. 1 to 2 weeks, tolerance develops with regular use. The 11th strategy is nitrate-rich vegetables. I discussed this in the arterial health video, but it's worth repeating because the mechanism is different. The enterosalivary nitrite-nitric oxide pathway. You eat vegetables high in nitrates: beets, arugula, spinach, leafy greens. The nitrate is absorbed, concentrated in your saliva. Bacteria on your tongue convert it to nitrite. You swallow the nitrite. It's converted to nitric oxide. Nitric oxide dilates blood vessels. Blood pressure drops. A meta-analysis of 43 studies showed that beetroot nitrate supplementation produced an average reduction of 3.55 millimeters systolic and 1.32 millimeters diastolic. The dose used was about 250 milliliters of beetroot juice, providing 6.4 millimoles of nitrate. That's equivalent to about 3 large beets. Other nitrate-rich vegetables. Arugula, 250 milligrams per 100 grams. Rhubarb, 240 milligrams. Cilantro, 245 milligrams. Butter leaf lettuce, 200 milligrams. Spinach, 180 milligrams. Beets, 110 milligrams. Target 300 to 400 milligrams of nitrate daily for vascular benefits. The timing is acute. Blood pressure reduction begins 2 to 3 hours after consumption. Peak effect 3 to 6 hours. Duration 6 to 24 hours depending on dose. Chronically, daily consumption maintains the effect. 60 days of regular intake produces sustained benefits. Improved endothelial function. Better nitric oxide production. The timeline is hours. Immediate post-consumption vasodilation. Days, consistent use, maintains nitric oxide production. Weeks to months, improved endothelial function. The 12th and final strategy is magnesium supplementation. Meta-analyses show that magnesium supplementation, average dose 365 milligrams per day, produces a 2 to 5 millimeter systolic reduction. Greater effect in people who are magnesium deficient. The mechanism is multiple. Magnesium is a natural calcium channel blocker. It prevents calcium from entering vascular smooth muscle cells. Without calcium, the muscle can't contract. Vessels relax. Resistance drops. Pressure drops. Magnesium also improves endothelial function, reduces inflammation, and enhances insulin sensitivity. Who responds best? People with magnesium deficiency. Indicators of deficiency include diabetes, diuretic use, which depletes magnesium, alcohol use, GI disorders causing poor absorption, and low dietary intake. Serum magnesium can be tested, but it's not always accurate. Intracellular magnesium matters more, and that's harder to measure. Magnesium-rich foods include dark leafy greens, spinach, Swiss chard, nuts, almonds, cashews, seeds, pumpkin, sunflower, whole grains, legumes, dark chocolate, and avocado. If you're supplementing, the dose is 300 to 400 milligrams per day. Forms matter. Magnesium citrate and glycinate are better absorbed than magnesium oxide. Oxide is poorly absorbed. It stays in your gut and causes diarrhea. High doses above 500 milligrams can cause diarrhea even with well-absorbed forms. The timeline is weeks. 4 to 12 weeks for full effect. Daily supplementation needed for consistent benefit. Now let me put this all together, the complete picture. When you combine these strategies, the effects are additive. DASH diet, 5 to 11 millimeters. Sodium reduction, 5 to 7 millimeters. Weight loss if you're overweight. 10 pounds is 5 millimeters. Exercise, 5 to 7 millimeters. Potassium increase, 4 to 8 millimeters. Stress reduction, 5 millimeters. Combined, DASH plus sodium reduction plus weight loss plus exercise equals 20 to 30 millimeters possible. This rivals multiple medications. But here's the truth about fast. What works in hours? Resonance frequency breathing, temporary during practice. Beetroot juice and nitrates, peaks in 3 to 6 hours, lasts about 24 hours. Reducing alcohol, within days. What works in days? Sodium reduction, initial water weight loss, sleep improvement, especially if you treat sleep apnea. What works in weeks? DASH diet, 2 to 8 weeks. Potassium increase, 4 weeks. Exercise training, 4 to 6 weeks. Weight loss, ongoing. What works in months? Meditation and stress management, 2 to 3 months for sustained baseline changes. Mind-body practices, 2 to 3 months. So the fastest interventions, breathing and nitrates, work in hours, but the effects are temporary. The most powerful interventions, DASH, weight loss, exercise, take weeks, but they change your life. The smartest approach combines multiple strategies, and the sustainable path focuses on lifestyle, not hacks. Thomas was 62 years old, stage 2 hypertension, 168/102. He was on 2 medications, lisinopril and amlodipine. His pressure was still 152/95. His doctor wanted to add a third medication. Thomas asked for 3 months to try lifestyle changes. His doctor agreed reluctantly. Thomas implemented everything. DASH diet with sodium below 1,500 milligrams. He ate potassium-rich foods, 4 to 5 servings of fruits and vegetables daily. He lost 18 pounds in 3 months. He started exercising, brisk walking 45 minutes, 5 days per week. He stopped drinking. He was having 3 to 4 drinks per night. He cut to 0. He started sleeping 7 to 8 hours instead of 5 to 6. He practiced resonance frequency breathing 15 minutes every morning. 3 months later, his blood pressure was 128/78. His doctor reduced him to 1 medication. Thomas continued. 3 more months. Blood pressure 122/76. His doctor stopped all medication. Thomas has been off medication for 2 years. Blood pressure stays at 120/75. He maintains the lifestyle. DASH diet, exercise, no alcohol, good sleep, daily breathing practice. He reversed stage 2 hypertension without adding medication, by attacking all 6 mechanisms simultaneously. Now, before you go, I want to tell you about something I've created specifically for people serious about controlling blood pressure. It's an ebook called the Hypertension Reversal Protocol. This is not free. This is a premium resource that represents 20 years of surgical experience and hundreds of hours of research. Inside, you'll find the complete science of blood pressure regulation, all 6 mechanisms explained in detail. The complete DASH diet meal plan, not just guidelines, actual meals, breakfast, lunch, dinner, snacks, shopping lists, recipes, everything you need. The exercise protocol, specific workouts, how to combine aerobic and resistance training, how to use isometric exercises. The stress management protocol, meditation techniques, breathing exercises, how to practice, when to practice. The supplement guide, which supplements work, which are worthless, exact doses, best brands. The monitoring protocol, how to measure blood pressure correctly at home, what times of day, how many readings, how to interpret the data, when to adjust your approach. Real case studies, patients like Thomas who reversed their hypertension, what they did, how long it took, what worked, what didn't. To get this ebook, click the link in the description. Join Senior Health Life Daily. This is an investment in your health, in your brain, in your heart, in your kidneys, in preventing the stroke that would destroy your life. Click the link, get the ebook, get the complete protocol. Now watch one more video before you go. Click the link appearing on your screen. It's called the one blood pressure medication that actually heals your arteries. Because not all blood pressure medications are equal. Some just lower the number. Some actually repair damage, reverse endothelial dysfunction, reduce plaque. One medication in particular has been shown to reverse left ventricular hypertrophy, to reduce cardiovascular events beyond what's explained by blood pressure lowering alone. You need to know which one it is. Click now, watch that video, and subscribe to this channel if you haven't already. Hit that button, because I'm committed to sharing truth, Mechanisms. Protocols that work. Not simplified advice that sounds good but doesn't address all the mechanisms. Not single interventions that drop your pressure 5 points and leave you thinking that's as good as it gets. The complete truth. All 12 strategies. All 6 mechanisms. The comprehensive approach that actually normalizes blood pressure. Subscribe so you don't miss it. Take care of your blood pressure. Don't settle for one strategy. Don't accept partial results. Attack all 6 mechanisms. Combine multiple interventions. Get your pressure below 120/80. Protect your brain, protect your heart, protect your kidneys. And remember what I said at the beginning. There is no single best way to lower blood pressure. Your body is too complex. Hypertension has 6 mechanisms. You need multiple strategies to address them all. Diet for endothelial function and arterial compliance. Sodium reduction and potassium increase for blood volume control. Weight loss if you're overweight to reduce cardiac output and sympathetic tone. Exercise to improve endothelial function and reduce arterial stiffness. Stress management to reduce sympathetic overactivity. Sleep optimization to restore normal circadian rhythm and nocturnal dipping. These strategies work synergistically. Combined, they can drop your pressure 20 to 30 points. That's the difference between stage 2 hypertension and normal, between medication and no medication, between a stroke and a healthy brain. Implement them. Track your progress. Adjust as needed. Your blood pressure will normalize. I'll see you in the next video.